laser companies. And it is us surgeons that we have to step up our game and say, no, you can do it, but you have to do it the other way. So, laser in fistula and anode, target the source and preserve the sphincter. That's our motto. Why laser in fistula? Filat eradicates sepsis, preserves continence, minimizes wounds, causes little post-op pain, allows rapid recovery, repeatable. Laser attempts to achieve this by obliterating fistula tract without dividing the external anal sphincter. It sounds so beautiful. Does it really work that way? A 1470 nm radial fiber is used in continuous mode at the rate of 10 to 12 watts per millimeter per second. It causes destruction of unhealthy granulation tissue, protein denaturation, controls shrinkage, and collapse of the tract and subsequent fibrosis. So, your question should be, why do you say it doesn't work? Because this is not what you are treating. Fistula is not the tract. Fistula is the source and the tract. And laser is only treating the tract. So we have to go one step ahead for this to really work. Laser treats the tract and not the source of infection, and that is where all the misery of the patient and all the misery of the surgeon lies, that the patient has a recurrence. What does laser does well? It preserves continence, minimal pain, daycare surgery, no large wounds, and can be repeated. In India, I mean, we are not very fanciful for daycare surgery. We keep them overnight. All of them we keep them overnight. This is more for the Western countries where they are very constricted by the number of beds, and then insurance company says, no, daycare should be there. Now, evidence, laser fistula closure, Filat, these are the results in literature, anywhere between 71 to 89%. And Dr. Kamal did in 2019 the same thing, Filat, 84%. And then it was changed to distal laser and proximal slough, which had a 93.6%. I was part of both the studies, and the third one, that is distal laser and proximal fistectomy, 96%. So, thank you, Kamal, for giving me this video. This shows what a Filat is actually being doing. So you've seen the fistula tract, you put an infiltrating tube, you put in between DO and hydrogen peroxide, you curate the tract, and after curating it, you put in the laser fiber, and once you put it there, you come out and you ablate the tract. And after you've done this, then you've got to put in some probe or something around which you're going to close the internal opening so that it's sturdy and it's closed, and you can see when you pull this, it's tight. So, this hardly takes 10 minutes, and irrigation shows that it's watertight, so you can't complain. Then why is it that post-op, this patient has an opening of the internal opening, and why is it that the patient does not heal and has a recurrence? That's where we have to step in, and that's where we have to see, are we doing the right thing? In one line, no. If you're doing Filat, I say you have more than 90% recurrence rate. Then why do you want to do Filat? Why do 10% heal? Sheer luck. Even if you hadn't done anything, it would have healed. So please don't give the credit to the laser for Filat. Laser has good uses, but it's in a different place. Why does recurrence occur? Internal opening is not identified in some cases, persistent infection of anal gland, residual intersphincteric sepsis, inadequate drainage, secondary extensions, horseshoe disease, distal tract persistence. The message is most recurrence originate from residual central disease rather than external tract, and it is this central disease that we're leaving behind. We are only taking a stitch to close it, but not doing anything about it. So we address this by excising the central disease. Now what we are doing is, we are doing various types of sphincter saving surgeries that includes laser, fixation, anal fistula plug, and waft. And yet, despite the fact that it's a beautiful technique, all of them, patient has recurrences. So what's going on? Where is the recurrence coming from? So you've done the tract, you manage the tract, but what do you see here? you see that the glands are still there, the glands are still infected, the pus is still there, and you haven't done anything for it. Sepsis is left behind, and the anatomy of central disease is you have the glands like that,
Tuh bang,
and
terspin
this is the
trik-triknya ya,
area of
kita belum
central
bakar.
disease. Internal
Hancurin aja
opening,
bang.
anal glands, infected
Bagus
hip,
hasilnya ntar.
intersphincteric tract, adjacent internal sphincter. In 2026, I presented in
Ingetin
London
aja tanda salib
my
cross.
technique of doing excising the central disease. And I had very big people sitting there in the audience. They sort of criticized me, and some said it's good. And I met in my meeting in Belfast last week Professor Piltozer. He said, you know what you told in 2024? That has been going on in our mind. And we started doing it since 1 year. So they've started doing the same technique since 1 year. And he says the result is good, we're going to publish. So it does work. Your surgeons, think about it. Why shouldn't it work? This is excising the... So what is the concept of central disease? Increasing evidence suggests recurrence rate arise from it, internal opening, infected gland, intersphincteric focus, rather than the distal tract. Laser should never replace proper source control. Simply destroying a tract will usually fail. Now, I want to show you this beautiful picture. We were coming back, Dr. Praveen Gore is not in the audience, and we were rushing to the plane, and he stood and took this photograph. I said, what's so big about this photo? Now he said, see Manchester, where it is on top? Suppose Manchester is the central disease, and all these are the fistula tracts. So unless you take care of Manchester, these tracts are never going to go away. So that is a concept of central disease. So, you know how people teach? I was taught that if you put this in Gemini and talk to it, you can get a video out of it. So I made a video I want to show you. I made it slow motion. So all the flights are originating from Manchester. That's the central disease. And going all across the world. So this is the central disease where the whole problem is. Now if you can manage the central disease, if you can excise the central disease, then all this problem, see how it's going towards the whole place. These are the various fistula tracts arising, intersphincteric, transsphincteric, suprasphincteric. Now, if you excise the central disease, what's going to happen is the tracts are going to go away because you manage the source. And this is also a teaching point for you that how you can take a picture and talk to it, and in Gemini you can make a video out of it. This video took 1 minute to make. Learning curve. I learned it in Belfast, in the airport while running to catch the plane. So what is the principle of central disease? You have 1, 2, 3. One is the source. The source goes up to the external sphincter. Hello? Yeah. So I've divided it into 3 parts, a whole fistula. This is the internal opening, the internal anal sphincter, and the intersphincteric space. This is the source of infection.
Yes.
What we are doing by laser, we are addressing this whole tract. But we are leaving behind this, and that's why there is a recurrence. So if you manage 1, 2 is the portion which is inside the external anal sphincter, and 3 is a distal tract which is outside the external anal sphincter. So I'm showing you what you should do for each step. First, 1, identify the internal opening, excise the infected hip, excise adjacent internal anal sphincter 5 mm cuff, remove intersphincteric abscess, preserve the external sphincter, and create dependent drainage. That is the drainage which is coming through the anal canal. Then what do you do in the external anal sphincter? Curate the defect. You can laser it also, but close it with 20 PDS over a probe, so you know it's very close. So what you have done is, you have recreated, you have closed this defect, so you have the barrier back again. And this is separated from this. So this barrier has to be closed, you can't leave it open. Then thirdly, distal tract is, you can curate it, You can do waft, you can do laser, you can do fixed surgery, you can do anal plug. They will be successful. So what happens is, when you're cutting it here, you're going through this place, you're excising this point. Think, you have an intersphincteric abscess. You have a high intersphincteric abscess which is totally above the dentate line. You have a high intersphincteric fistula. You have a supralevator abscess or a fistula. How are you going to approach it? You take this out. The internal opening, you lift with forceps. External opening, you push back with your retractor. So this whole space, the deep intersphincteric space, is at your hand. You can do any fistula surgery with this. Once you can master this, you can master fistula. So complex fistula, when they used to come before, I used to get nervous what to do. Now when they come, it's like it's a challenge. Take out this and everything else becomes easier. So even if you have a fistula which is going from one side to the other side, this space is open, you can do anything. So you can go up, you can go down, and you can go across. That's the beauty of this.
Yes.
Now, if you excise this, and if you put it on modified parks, this is type 1. All the places which are yellow are the central disease excision. And this is type 2 and type 3. Wherever you see yellow is a central disease excision. And type 4, only one place will be there. So these red boxes, you don't need to do it because there's nothing there, it's not touching them. For the first red box, A1 and B1, tracheotomy is the best treatment. Don't do any laser, don't do any other techniques, that's the best way to out. So how do we excise it? So I'm showing you a video showing that. Your friend is saline adrenaline. I used to use xylocaine adrenaline, saline adrenaline. It is very vascular. So once you made it out, this is the portion I'm going to cut. Now you can cut it with cautery, or you can cut it with laser. It's totally up to you. Skin doesn't cut well with laser, so skin you should use cautery. That too, cutting
Bang,
board,
saya bilang
not
ini, Bang.
coagulation.
Yeah.
And when you're going towards the
Open
mucosa
na
and
naman
going
po,
down
Fatima.
deeper, that's when you use coagulation.
Ah.
So I'm taking out the source of this whole problem, the source of our misery. That is where everything started. So excise the central disease. I'm going to repeat over and over again because I have seen, and all my colleagues have started doing the same thing. I thought my results were good, but everybody's results has improved. And initially when I started, I was quite skeptical. I was scared what might happen. We're scared of the internal anal sphincter. Well, you have to know you can sacrifice the internal anal sphincter up to the anorectal ring. And once you close the external anal sphincter, and you can close this mucosa and internal anal sphincter, leave a small amount gap in the bottom. Why do you want to close it? Because I used to leave it open, then I used to muscularize it, then I took interrupted stitches. They all were causing problem. When you take a continuous suture, it doesn't cause a problem. So, post, what do? You pivot the base, explore the intersphincteric space, identify the internal anal sphincter, external sphincter, and you can leave it open, you can do interrupted and continuous. Now, coming back to the same diagram, if you have taken out the source, everything. Now, access to intersphincteric space for all these types of fistula is from the internal anal sphincter. Now, this is the last 3 months. Each diagram looks scary, but if you know how to take out the central disease, it is no more scary and it's simpler to do. So, there are 2 central disease excisions. On left side you're doing it with cautery, and on right side I've been doing it with laser. I use waft to see the tracks, only for the tracks, and sometimes I go in the intersphincteric space. I've been told by Arshad, hurry up, your time is up. Almost. And I'm going to be excising the central disease in both. And the one on the left, you see me curating. I'm curating the large, high abscess which is there. And after curating it, put the scope inside and clean it. And people keep saying, why should you buy the scope? This is why you need the scope for something which is unapproachable otherwise. And excise the external opening. So, now high transmitting fistulas, it can easily be done by taking care of the central disease first. What happens, how is it different here? You hold on to the central disease with an Ellis forceps or a forceps. You lift up the internal anal sphincter and you push back the external anal sphincter. You can go all the way up to the point where it goes through the external anal sphincter. So once you realize that everything follows this pattern, operating fistulas with laser is become simpler. So you see, I'm lifting up both the places. Sometimes the root of fascial spread is going up and is going across to the scrotum. Thank you, Arshad, for your pictures. He gets really mean fistulas, and this is Dr. Arshad's patient with abdominal fistulas. So you see multiple incisions already there, and he's exploring it, and there's a wound down. So when he's putting saline from there, it's coming from below. The tracts above can be managed by waft. The tracts below, you have to take out the central disease. This is excising the central disease, taking out the source. Everything else can be cleaned with waft, laser can be put in, the tracts can be burnt and curated, and it's going to heal. This is laser ablation of the tract, healing at 6 weeks. Supralevator abscess, old man, 80 years old, he has a large supralevator abscess. You know how to do it, it's very simple, everybody can do it, but when you do it with excision of central disease, recurrence is less. Always remember, when you are tackling abscesses like this or anything intersphincteric, the discharge is more for a couple of months. And this patient, fortunately, within 3 weeks, the whole discharge stopped. I took out the central disease, went inside. He had a large lump in the rectum, which was drained through the intersphincteric space. The waft was put in. The abscess cavity was cleared out. And the tract, which was going up to the abscess cavity, was laser ablated. So this is the laser which is inside. That's the laser fiber. Once I put it through the scope, and the second time I put it just like that. Keep rotating it all around. And that's at the end. So current evidence says primary healing is 55 to 75%. Pooled success 65 to 70. This is for routine phylac, which I don't agree with. Why laser works best in these fields? Poor indication for laser. Most laser failures are biological. They're not technical. So I talked about it in the beginning. Hybrid approach is laser with waft, curettage, internal opening closure, advancement flap, lift, prolonged drainage. Current guidelines suggest sphincter preserving options, suitable and selected patients, safe, associated with modest healing, supported by low quality. Advantages, which is claimed, is not correct. Limitation, obviously we know the fiber is expensive, healing is not good in phylac, does not eradicate the central disease, higher recurrence in complex fistulas. Future direction, Dr. Pradeep has already talked about. So now, what did we learn from laser and fistula? Is a sphincter preserving technology, not a cure. Greater strength preservation of continence. Healing rates modest. Laser treats the fistula tract but not eliminate the underside septic focus, so please do that. The future lies in laser and sound surgical pencil and hybrid technology. And that is all which is really going to help you. Thank you so much. I hope you take away some things from this. So I have been told by the organizers now you are excited to work up. Okay.